You're listening to Boomers Today with your host, Frank Sampson.
Welcome to Boomers Today. I'm your host, Frank Sampson. Of course, each week we bring you important and very useful information on issues facing baby boomers, their parents, and other loved ones. And as I do on each show, I just want to thank all of you for all your support. So many of you have shared our podcasts or individual shows with friends and family, and our listeners are growing each and every day because of you. So I want to thank you for that. So many of you listen to the show on, maybe on your favorite podcast station, whether it be Apple Podcasts, Google Podcasts, Spreaker, Stitcher, iHeartRadio, a lot of them. Some of you have gone right to our website at boomerstodayradio.com. So thank you. Keep up the good work. And I know why you're doing that. It's because we have wonderful guests. I'm not going to disappoint you today. We have with us Dr. Reznik, who is a board-certified orthopedic surgeon specializing in arthroscopic surgery and sports medicine. I may need him. Connecticut Magazine has named him a top doc for more than 2 decades. He's also recognized as one of America's top physicians by the Consumers Research Council of America. Widely published with over 60 journal articles, Dr. Reznik is also the author of I've Fallen and I Can't Get Up. Can Get Up. Oh, you caught me there. I Can Get Up, a guide to fall risk and prevention. He holds a number of orthopedic patents, and his personal mission is to help readers, patients, and concerned family members better understand their own road to recovery by sharing decades of his orthopedic medical knowledge. Dr. Reznik, thanks so much for joining us on Boomers Today. Really appreciate it.
Thank you for having me. It's great to be here.
Yeah, I mean, this is a subject matter, certainly, I'd say my age group, it's probably a daily conversation. And certainly I know our listeners are certainly interested in what we're going to talk about. I thought maybe we'd just start out, tell me a little bit more about your book, which I made a mistake because of that crazy commercial, whatever product was, I've fallen and I can't get up, but yours is I've fallen and I can get up. Tell us more about the book and kind of who your target audience is. Tell us a little bit more about that.
Okay, so we have 2 books actually we're going to talk about today.
Oh, okay, great.
Right? Remember that?
That's right. Let's do
the newest book is the Knee and Shoulder Handbook. The older book is the I've Fallen and I Can Get Up. The Fallen and I Can Get Up, I'll touch on that for a minute. I couldn't sleep well when I kept seeing that commercial. The older person has got the button and they're lying on the floor with a broken hip and they can't get up. And I'm thinking to myself, this is, as an orthopedic surgeon, this is awful. We need to really focus more on not falling in the first place.
I agree.
So I was dreaming about it it must have been 3 years in a row. I'd have these dreams about these commercials and it really bugged me. And I finally said, I got to write the opposite. I got to write this book called I've Fallen and I Can Get Up. Problem is when you search for it on Google, it keeps giving you the old commercials. You have to put my name, Dr. Reznik, in there, Reznik, to find it. Otherwise you won't find it. But it's on Amazon, and it's a separate guide to all the reasons why people fall and how you prevent them. And even when someone falls, how do you diagnose what happened and how you treat it? And it ranges everything from eye issues to ear problems, central nervous system, balance, unable to feel your feet.
It could be medications, right?
Medications, heart disease. I mean, it covers the gambit, and it also talks about safety things you could do in your own home, how to change things around. So that's a whole nother show, I think. And I'm happy to do that at another time. But for today, I want to go back to maybe a little bit before that Fallen book and talk about things that tip-offs in the knee and shoulder that are problems that you don't recognize right away that really affect your quality of life. And at the end of the day, when you're compensating for a knee or shoulder problem, you're probably more likely to fall and hurt yourself anyway. So they're not disrelated to the same population, but also it affects people from teenagers all the way up to older adults, because we see people with knee and shoulder problems all the time. I know you told me you love pickleball, right, and that's becoming very popular. And for me, pickleball is a little bit of an annuity plan because we got a lot of knee and shoulder problems coming out of that. So we can talk about that as well.
Okay, so let's do it. So let's. I mean, I've had some knee issues and had several years ago arthroscopic surgery, actually a couple times. And so I remember I had what they called water on the knee. This is many years ago. It wasn't a pleasant experience when they removed it, but talk about that. What's water on the knee? What is that?
Yeah, water on the knee. You know, in fact, it was just a grand rounds at Yale. I'm a part clinical faculty at Yale, and we had grand rounds this morning all about arthritis and things that cause pain in the knee. And the reality of it is there's two things your knee can do when it's pissed off at you, to put it in common terms. And one is make water or fluid, which is the lining produces fluid to help lubricate your knee. And the other is to hurt. And lots of times it does both. It makes water and hurts. The interesting aside about the water on your knee, which people don't understand, when the knee swells, your brain turns your quadriceps muscle off or lowers its ability to contract. And the reason it happens is spinal cord reflex, not known by a lot of people. The body understands there's something wrong, so it doesn't want to load it up. So then you don't load up, you have a knee to gait, you perform poorly in sports and so on because there is water in the knee. But rolling back to why there's water in the knee, there's really mechanical issues and chemical issues, right? So the mechanical issues are I tore my ligament, I tore my cartilage, I hit my knee with a hammer by accident, I fell on it. Those are mechanical things. The knee is unstable, it's buckling, it's giving out. The knee will then swell afterwards. Sometimes it swells very fast after an injury because you might have chipped the cartilage or tore a ligament, and then it bleeds, right? You've bled into your knee. That's one kind of swelling. And sometimes you hurt yourself and it swells the next day or 12 hours later, and that's synovial fluid is building up. On the other end of it, it's things like gout and rheumatoid arthritis, Lyme disease. All those things can cause your knee to swell. So it's really important for the patient to recognize a chronically swollen knee that's not going away needs to be sorted out. Do I have a chemical problem or a mechanical problem? Both are very treatable, but the swollen knee will limit range of motion, your ability to bend. It will decrease your quads function, which will make your leg weaker over time and probably make it more likely to lose quality of life, right? So if your knee is swollen for 3 weeks and it's not getting better, you really should see an orthopedic surgeon and have it checked out.
Yeah. Right. So a lot of these issues, people you're dealing with that are, let's just say, elderly people. All right. Let's just say that have some of these issues. You think this is just or most of the situations, things that just happen over time as they age, or recent stuff that happened to them?
Yeah, I think there's a bit of both. I like to tell people, I never tell people they're old. I hate saying that because I feel like I'm getting older myself. So,
well, getting older is one thing. Getting old is different than getting older.
Right. I always say there's mileage on the car.
Yeah.
And you can drive like Mario Andretti, or you could drive like my grandmother. If you drive like my grandmother, the tires will last forever. If you're driving like Mario Andretti, you might have to have a tire change at some point, a little sooner than later. So there's wear and tear, and that everyone gets some of that. Some people are probably genetically predisposed to more of it than others. For example, people who are very much knock-kneed or very bow-legged, they tend to wear out unevenly. Just like if you imagine a tire in your car was misaligned at the shop, you'll get uneven wear, right? You go back for a realignment, it helps. So when you're younger and you're very, very bow-legged, like some people have severe bow legs, or some people have very, very severe knock knees, and you're young and you're in your 30s and 40s and you're starting to have knee pain, you might be a candidate to get the knee actually straightened. I do actually operations for that. We cut the bone, straighten it out, put bone graft in, fix it, and it relieves a lot of symptoms. If you have a little bit of bowing, some people do well with a brace that unloads the knee for sport, and that works really well. But those patients should really carefully look at that. If that's starting to bother them and they have really bowed legs or really knock-kneed, then that's something we should look at separately. The other people, that legs are pretty well aligned, but they may have hurt themselves when they were a kid. Maybe they had torn cartilage or torn ligament when they were younger. And that always goes along with some cartilage damage, and then that eventually catches up with you at some point, no matter what you've done. If you've damaged the knee, it's not going to have the mileage.
When you say catches up with you, be a little more specific. What does that mean? It catches up.
Yeah. So let's say I had an ACL tear when I was in my teens, and then I had it fixed, and I did well, and I returned to sport. People don't realize as you tear your ACL, the knee partially dislocates, and then it pops back into place. And in that process, it does bruise the bone and the cartilage. And there's some data that shows that that does kill cartilage cells. And as a result of killing those cartilage cells, you have less cartilage, viable cartilage for a longer term. So your tire is going to wear out a little faster. So if someone's still a heavy athlete and tore their ACL and had to repair it and they're doing great, I'd still anticipate they might wear their knee out faster than someone who never had the injury. And that kind of makes a lot of sense, you know?
Right.
So, you know, if you have a bad tire in your system, riding over the potholes all the time or doing moguls with skiing, but you know you have a terrible knee, if it swells every time after you do it, you know you're hurting yourself because your body's saying, hey, I don't like this. I'm trying to let me see if I could lubricate my knee. It'll be better. So it makes a lot of fluid, and you say, well, what is that recurrent swelling? Yeah, your knee's complaining, you know, that you're doing too much, and it's letting you know.
Yeah. So some of the things that I know I deal with, and I mentioned you that I started a company, and we work with the elderly and adult children. So let's when an adult child is dealing with a parent or other loved one and they're having issues, and I guess it kind of depends what kind of issues, but it could be from an old injury, it could be wear and tear, whatever it may be. How do they like determine, you know, mom's going to be 90 or, you know, somewhere in that zone. I don't want to put him or her through surgery, but then maybe other than that, they're in pretty good health. They're doing okay for their age. Like, how do you determine, you know, should you do surgery? You know, I'm sure every situation is different, but can you give kind of an overall viewpoint to that?
I think the answer to that question has changed over the last 30, 40 years. You know, I started medical school 40 years ago, and the answer to that question was, yeah, we don't operate on those people if we can help it, because anesthesia was the major trouble. You know, you'd give someone 90 years old an anesthetic 30 years ago, a lot of them stayed in your fat for weeks afterwards. They disturbed your sensorium and mentally depressed people in the sense of function. And for some people, they never really recover from that. And certainly 90-year-olds, we used to be very nervous about giving them an anesthetic. The anesthetic agents have changed, the safety has changed, the ability to do minimal anesthesia with spinals and epidurals and, you know, blocks has changed things so much that we now find that the quality of life loss, if someone, let's say mom is got a very, very bad hip and they fall and they break it, instead of fixing that hip, we'll replace that hip, because the replacement of the joint will give them better function than just fixing a bad hip. So we do that for the last 10, 15 years. That has become the new standard for broken hips. If the hip joint is really, really bad and the hip fracture is at the ball, we'll replace it because they'll get much better function. And they function better than they did before they fell, which could prolong their lives and make their lives better quality. So then taking that forward one more step, if you have someone who's 80 years old who has a very dysfunctional, bad arthritic hip or knee, and you say, well, we can safely replace that knee and improve their ability to walk, and we know if they can walk every day 20 minutes, it's going to improve their health. Not only have we gotten rid of the pain they've had, but we've actually enabled them to have a better quality of life. And so now we look at someone who's 80 and say, all right, you're only 80. You know, it's kind of funny. You're only 80. And you can't walk. And what's your favorite thing to do is to go on Sunday and walk by the beach, you know, with your dog. And even though you only walk a mile every Sunday, you know, that's something you look forward to. Or maybe now you want to do it every day, but you haven't done it in years every day because your knee's been so bad. Those patients do really, really well if they're in good health with a knee replacement. And so I think that sometimes we do a disservice to someone who's elderly, not addressing some of those problems. In other cases, maybe the knee is swollen, maybe it's arthritic. We know that the lining tissue and the periphery around the knee is what really gives you pain. And osteoarthritis as well as rheumatoid arthritis can give you lining tissue that's inflamed. So maybe a cortisone shot would be awesome, you know, and give them some temporary relief. Now, the data is really that cortisone gives you, you know, temporary relief, and some people that lasts 3 months, 6 months, sometimes it lasts 3 weeks. But sometimes acutely, it's so painful that doing that really gets them out of that danger area. And then maybe supplement it with an anti-inflammatory medication, a little bit, you know, something that's prescription strength, but safer for the stomach, let's say. And maybe between the two and maybe a brace, they're more functional. maybe a little therapy to strengthen that leg that's weakened because you haven't used it makes them more functional. And even that will improve quality of life. So I think we got to hesitate less when the quality of life is drifting away. And it's always better to act earlier than later with some of these things, because sometimes you catch it earlier, the person's healthier, they actually get more value out of it.
Great. We're going to take a real quick break, I promise, just to recognize our sponsor. And we come back, we'll give you the opportunity to tell people more about both your books, how they can get them, anything else you'd like to share. And then I want to talk more about what you brought up about hips and those that might have broken their hip. And I want to talk a little bit more about that because we deal with that quite often.
Sure.
All right. So, so do you know anyone who may be concerned about an older driver? Well, Senior Care Authority's Beyond Driving with Dignity program is a facilitated self-assessment program for older drivers. This program has been designed to serve as a vital tool to facilitate older drivers and their families as they make appropriate decisions regarding the future of one's safe driving career. If the individual is a safe driver, an advisor will provide him or her with strategies on how to remain a safe driver as they progress through the aging process. If driving retirement is the appropriate decision, then the individual and their family are offered possible alternatives, resources, and a specific plan to ensure a smooth transition from the driver's seat to the passenger seat. So to learn more, you could go to www.beyonddrivingwithdignity.com or call 877-907-8841 to connect with a Senior Care Authority advisor in your area. So we're back with Dr. Alan Reznik, who's a board-certified orthopedic surgeon, and we're talking about all sorts of our body and how it sometimes may start to fall apart and how he could fix it and others in his field can fix it as we age. So Dr. Reznik, I know I brought up one of the books in my intro, but I know you have another book. Maybe you could just chat a little bit about both and how people can get the book and anything else you'd like to share.
Sure. So a couple of things I'd like to share. One is I do have my own website. It's drreznik.com. It's Reznik. It's an unusual spelling, so if you do anything different, so it's drreznik.com. And on there, I have a lot of patient information, about 18 videos of different surgeries, what they look like on arthroscopy, and you can actually see the little surgical procedures being done. And I have links for the book, and I also have patient safety articles and some other public information stuff, because I've been doing a lot of writing for a number of years for the Academy of Orthopedic Surgeons that have to do with patient safety. And then there's some special articles about specific problems. So sometimes you can find some stuff there that you can't find anywhere else. It's helpful, and then you can find links. Both books are on Amazon online, and you can just go to Amazon.com and find my author page, and then find the books, or you go to my website and get them. But they're written in a style, especially the knee and shoulder book. It's more of the style. I'm having an office visit with you, and I'm trying to unravel the things that your doctor might say to you that you don't understand. There's a glossary in the back. There's little anatomic drawings. There's X-rays and MRIs with circles and arrows. So you can understand if the doctor shows you something, you could find it in my book and then look at it by yourself and maybe get a better understanding. When I wrote the book, the intro, I said, remember Peanuts and the school teachers used to talk to the students, and the teachers used to sound like wah, 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 wah. And I found that if I say the word surgery to anybody in my office, and I wrote this in the intro of the book, that it immediately becomes wah, 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 and everything I say after that disappears. And I ask them next week, remember when I told you this? And they say, no, they don't remember. So the book is really all about fixing the wah, 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 wahs. And if you have that experience yourself, I think you'll find it very helpful. Getting back to the problems we were talking about, I want to touch on the next level below the knee replacement, because if you're waiting to get the knee replacement, it may be too late for some people, and other people have things that can be treated differently. So like one of the things that generates pain in a knee is a torn meniscus that's catching, right? Another thing is a bone that's bruised that won't heal. Those things can be treated arthroscopically, outpatient surgery, minimally invasive, a very light anesthesia like supracolonoscopy with local. much safer than a more general anesthetic. And so if you have a problem that later on is going to disable you and you're kind of putting it off until you're disabled, it's also a thing, come in early or get it fixed by a more minimally invasive procedure. Don't wait till you need your knee replaced. Oh, I've been holding off for 10 years waiting for my knee replacement, but I could have had something done 10 years ago that would have improved my life, and I didn't do it. That's not a good story.
But at what point do you think, because I'm one of those people, right?
Yeah.
So at what point do you think, hey, go in and, have this checked, where it's just, I mean, I have pain, for example, but not like pain all the time. But and I had surgery, done some years back. But all my friends, oh, you're going to have to get it replaced. I don't know if I have to get it replaced, but at what point do you
Well, that's always surprising to me. Like sometimes I see people who come in and you take an X-ray and the knee is really shot and they have no pain at all, and you can't figure that out, right?
Okay.
And then you have other people, their knee barely looks like there's anything wrong, and they have terrible pain, and you don't really know why. So, I mean, if the knee cartilage looks good on X-ray and you have continuing pain, it's worth trying some simple things, anti-inflammatory cortisone shot, therapy, those things first. And then if those things don't work, and you give it a good college try, getting an MRI to see if it's one of those simple things that, okay, yeah, you have a torn cartilage, it catches every once in a while, and you get that out of there, you'll feel better. Or there's a loose body that's moving around and you get that out, you'll feel better. Or there's a big bone bruise, and if I can get that to heal, you'll feel better. Those are things. And the shoulder is the same way. People come to me for shoulders. Very funny. I have a torn rotator cuff. It'll drag for a long time, but at some point, people with shoulder problems tend to not be able to sleep at all. They can't get comfortable at night. And they come to me only when they're not sleeping. They go, how long is it hurting? 3 years. Says, why are you here today? I can't sleep anymore. So can you reach to the shelf and get the coffee cup out of the way? No, I can't do that, but that's been 2 years of that. But now I can't sleep, so it's terrible, So, yeah. If you can't reach the cup of coffee off the shelf without pain, sometimes that's a more minor problem to treat. And a little cortisone shot, some therapy, and also anti-inflammatory for that may work great. Or you maybe have the beginnings of a rotator cuff tear, if they treat it early, it's not going to turn into a big one. It'll be easier to treat. The recovery will be much faster. So again, if something's nagging for 3 to 6 weeks, okay, fine. If something's recurrent and it's 3 to 6 months, and you're stopping certain things because it bothers you, maybe look into that. Maybe there isn't anything we can do, but maybe there is something we can do, and if we can, maybe it makes a big difference to you at the end of the day.
Yeah. So I want to go back to hips, and the reason I want to bring that up. When I started in the business in the senior care industry, there's been a perception, and there's still somewhat of a perception out there, which you made a statement before that may not be true anymore. And that is, somebody breaks a hip. I'm talking somebody older, a little more frail, they break a hip, and then, everybody says that's the end. I mean, they're just going to go downhill from there and it's over,
yep.
Right?
Yeah.
How is that? It doesn't seem, based on what you said before, that has to be true. And why was that? Why was it that, or why is it still that perception?
Yeah, this is always the chicken and egg question, right? What came first, the chicken or the egg? And I always say it's the rooster. So, and the reality is sometimes people fall and break their hip for reasons that have less to do with the hip. Right? They're medically failing. They're losing their balance. Their electrolytes are out of whack. They've had a cardiac arrhythmia. There's a million reasons to fall that have nothing to do with the hip. And the bones are osteoporotic already. They're older. The bones are osteoporotic. Other people fall because the hip is so weak and the muscles are weak and the muscles are fatigued. And they fall because the hip cracks and then they fall. Right? So those are two different scenarios, right? The problem is if the hip is a symptom of something that's bad underneath, so like you're very osteoporotic, your body's fragile, you're out of shape, things are not going well, your balance is poor because there are a million reasons for that, and your electrolytes are out of whack, and you have heart disease and blah, 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 and you break your hip. Yeah, the stats are not that great because the hip is the tipping point of things are so bad I can't even walk normally without falling and hurting myself, right? And so those patients are in bad shape for a lot of reasons other than the hip, and the hip is just the tip of the iceberg, if you will. And yes, you break your hip, the prognosis is poor in a lot of those cases. On the other hand, if you trip over something, you're reasonably active, you have a little osteopenia, and you break your hip, and you have maybe some arthritis underneath, and you go ahead and get your hip replaced, that's going to solve a lot of that problem, because probably the reason you tripped and fell is because you had arthritis in the hip in the first place. So if you separate those two different types of hip fractures, you're going to see probably different outcomes. So, but in the old days, most hip fractures were really people who had so much going on medically, they really couldn't manage ambulation. And the story is, the predictor of a hip fracture is falling and breaking your wrist the year before. So someone falls, breaks their wrist, and then when the next year, the likelihood of breaking their hip is higher, right? And it's not because the hip is bad per se, it's because you're osteoporotic and you're prone to falling, and you're prone to falling because you have other medical issues that are affecting your ability and balance and the rest of your sensorium and everything else. So it's a package deal, right? Now, if you start to unpeel the medical issues, okay, there's an arrhythmia that's not in control. We have great drugs for that. Okay, your electrolytes out of whack. You need to take Gatorade once a day, whatever it might be, or your protein levels are so low because you're poorly nourished and everything's not working right. Or you have the beginnings of kidney failure, whatever it might be. If you can unravel all the medical problems and treat those well, and we can treat so many of them now, and fix the hip, your prognosis is probably better.
Gotcha. That makes a lot of sense. Makes a lot of sense. Thank you for that. So what advice can you give? And I know you talk about it in your book. I don't expect you to give it all away. We want people to go out and get your book, but as far as advice that you can give to people on some of the questions they should be, when they meet with their doctor, what are the top questions
right.
they should be asking?
Yeah, I have a section in the book about how to prepare for a doctor visit, because I think people come unprepared. Like obviously we need to know your medications and other problems you might have, but people also need to help being a good historian. I always say that 90% of all diagnoses in my field are made between the history of the injury, the person's medical history, and an x-ray, a plain x-ray, not an MRI. And that's a little bit of one of my pet peeves, is that so many people come to the office, don't I need an MRI? And my answer to them is, well, I've been doing this for 34 years. And if I was wrong all the time, they probably would have arrested me by now. Right. So the reality is I have a very good idea from your physical exam and the findings on the exam, your history, the story of how you hurt yourself, your medical issues, and a plain x-ray. I know 90% of the time what's wrong. And then the question is, in the fine points of getting an MRI, for many patients, it's helping me pinpoint exactly what I might do with surgery and adding in some things you might not be able to see on an x-ray. So if I'm thinking you need surgery for a problem, I might want an MRI. Now, there are other rare occasions. You're ruling out a tumor, you see something on the x-ray, you want an MRI or a CAT scan, depending on what it is. There's specialized reasons for both. You might get that study sooner than later if I'm thinking about those things. Or it's very obvious you need surgery because your knee is grossly unstable, your shoulder, you can't lift your arm at all, and you have an obvious rotator cuff tear. I might get an MRI because we're going to plan for surgery. I might get MRIs quicker in those patients, but most patients, I like to kind of give them a chance to kind of present everything is wrong, figure out what's wrong with them, give them a good talk about the range of possibilities, what's wrong, and the options, because surgery isn't the right answer for everyone. So I think that people have to come in prepared to understand that their doctor has to help them decide what the next test might be. And that the reality is being the best historian you can and giving it, letting them give you a good exam. A lot of patients go in my office, they get their x-ray, come back, put all their clothes back on. And I come in the room and I said, I am going to examine you, and they say, you are? I said, yeah, I really need to examine you to figure out what's wrong. And they're surprised sometimes, and I hope that makes me wonder, but a good exam is so important. And even a comparison, like I examine both knees every time I see a person for one. I don't examine one. If you're terribly bow-legged on one side and you're bow-legged on the other, that means something. If you're bow-legged on one side and not bow-legged on the other, it means something else. So, and then the patient tells me, oh, by the way, I had a tibial plateau fracture when I was 17 years old and never got treated. So you didn't tell me that before. Oh yeah, I didn't think it was important. So I learned a lot from patients by examining both limbs. And I had one the other day. They had a terrible squamous cell tumor on their forearm. and they were supposed to have surgery. And I said, wait a minute, has anyone looked at this? And they said, no. I said, you should. Now he came back 3 months later. He had Mohs surgery. He had the tumor removed. It was a squamous cell tumor in his arm. And now that's all cleared up. He can now have his surgery for his knee. But, people have stuff they don't show people, and some of it's important. So let your doctor examine you and be a good historian. If there's something else that bothers you, show it to him,
Great. Dr. Alan Reznik, thank you so much for joining us on Boomers Today. Check him out at Dr. Reznik, DrReznik.com, right? I get it right?
Yes, that's correct. You got it. R-E-Z-N-I-K. Thank you so much.
Thank you. Everybody be safe out there. We'll talk to you all soon.
You've been listening to Boomers Today with Frank Sampson. To learn more about today's show, visit boomerstodayradio.com and join us next time for another edition of Boomers Today.